Our next section is identification of risk factors. This is going to be very important, particularly on the first prenatal visit. This slide shows the variety of risk factors that we're going to assess. Obstetric risk factors look at what happened to the previous pregnancy. Was it a term pregnancy? Was it premature? Was there placenta previa? Was there bleeding? Was there abruptio placenta? Was it a vaginal delivery? Was it a forceps delivery? Was it a cesarean delivery? Medical risk factors, and we're going to look at these in some detail later on. Is there cardiac disease? Is there diabetes? Is there hypertension? Are there seizure disorders? Thyroid disease? Variety of different medical ones. Are there surgical risk factors, such as a previous abdominal surgery, which could lead to scarring? Was there a gastric bypass that was done? Social history is going to be important. Is a patient living on the streets? What's her socioeconomic status? What's her income? Family history is going to be important. When we look at, is there genetic diseases which are passed from parents to children? Is there history in the family of stillbirths, of mental retardation, of birth defects? Sexual history is going to be important in terms of HIV screening, gonorrhea, chlamydia, syphilis, number of lifetime sexual partners, current sexual partners. Lifestyle is going to be important in terms of alcohol, in terms of tobacco, in terms of street drugs, and teratogens, the medications, x-rays, which could have caused potential problems. And these are going to be important in triaging the patient. We will triage the patient through risk assessment. If it is a low-risk patient, we will see her according to the standard protocol, which is monthly for the first 28 weeks, every other week until 36 weeks, and then weekly from 36 weeks on. But if she has high risk factors, we're going to see her far more frequently. Let's say, for instance, she comes in and she has type 1 diabetes and her blood sugars are 350. You're going to see her in a month? No, we're probably going to admit her for diabetic control right away. If she has hypertension, if she's got heart disease, we're not going to see her in a month. We're going to see her far more frequently. So triaging the patient according to risk assessment is going to be incredibly important in prenatal care. So in our summary slide, we look at identifying if she is pregnant, and how do we do that? We identify what is her gestational age and the various methods of that, and then we want to look at risk factors and triage the patient based upon what those will be. Laboratory tests we'll look at later on, and the prenatal visits I alluded to. If she is low risk, we will follow this sequence. We will see her every 4 weeks up to 28 weeks. We will see her every other week from 28 to 36 weeks, and then we'll see her weekly from 36 weeks on. And the reason for this difference in the frequency of visits is the likelihood of problems developing increases as she gets further down the road. Hypertension, diabetes, preeclampsia, intrauterine growth restriction, those sorts of things. All right, that is the end of our section on identifying risk factors.